Hello, everybody. It's great to have you. And first of all, I would like to thank CyberSight and Orbis. As you know, this has been a fantastic resource. Well, I'm a little biased, I guess, about Orbis and the CyberSight because in 1999, I think, we had formed the CyberSight with Dr. Gene Helveston, and that's how my journey in ophthalmology somewhat had started, and moving on forward. I am, again, a professor of ophthalmology. I'm currently the Boomer and Jill Bernstein Endowed Chair and the Director of Akron Children's Hospital Vision Center. I'm a professor of surgery at Northeast Ohio Medical University, and also a professor of biomedical engineering in Case Western Reserve University School of Medicine. I do serve in many capacities. I do serve as the Vice President of the American Association for Pediatric Ophthalmology and Strabismus, and also serve as the Advisory Board Chair of the International Pediatric Ophthalmology and Strabismus Council. Also, I'm a past president of IPOSC, and also I serve as the Editor-in-Chief of the Knights Templar Eye Foundation Pediatric Ophthalmology Education Center and the Virtual Reality Education Center under the American Academy of Ophthalmology One Network. It's a mouthful, but it has been a journey, and I'm going to share some of the initiatives that we had started all the way from when I got involved in the CyberSight about the online educational platforms that led us to today where we are, and some of the simulators that you will see live on how to utilize them, and maybe some insight on how we built and why we built them. I do not have a relevant financial disclosure, but I do have a vested interest in IPOSC's mission to work together to preserve and restore eye health and enhance visual function in children and ocular alignment and binocularity in children and adults throughout the world. With that, I would like to give a quick outline. Today, again, we're going to talk about the American Academy of Ophthalmology Pediatric Ophthalmology Education Center outline. And also we're going to talk about the retinoscopy simulator, the various strabismus simulators. We have a basic and a complex. And we're going to also talk about the American Academy of Ophthalmology Virtual Reality Platform or Education Center and its first module, the ROP module itself. Today I'm going to talk about as mentioned, the Knights Templar Eye Foundation Pediatric Ophthalmology Education Center, along with Dr. David Epley, who is a past president of APOS and wears many hats, including director of American Board of Ophthalmology. We were tasked to form the biggest library of pediatric ophthalmology online. We went live in 2014, so a little bit more than 11 or 10 years ago. But in the 10 years that we were seeing, this has been truly the biggest educational platform that AAO has, and for pediatric ophthalmology for sure. Total views of 6 million, and the visibility is from 215 countries. So if you haven't utilized this website, I really urge you to go because it's free. Everything we're going to talk today is free to every one of you, and you have an access. The full access is only limited in the last portion that we're going to talk about, but the vast majority of what you're going to see is going to be available for every one of you right now, and has been available for quite a while. And the vast majority of the people who join the website is actually out of the United States. And these are the visitors. So people have been increasingly learning and utilizing the website because we have been updating the website and trying to put relevant information to do with pediatric ophthalmology. It was, as mentioned, first formed in 2014, launched in 2015, November, created by more than 200 volunteer pediatric ophthalmologist clinicians and researchers. These were the experts and subject experts in amblyopia, childhood malignancies, cataracts, glaucoma, and many other subjects. And along with that, we kept expanding on this. Today, when we look at the content, we have disease chapters and multiple licensed book titles. These are all free access. You do not need any login information to reach to these free online entities. more than 700 plus new surgical videos, lectures, interviews, and advances in pediatric eye care. There are 4 different simulators, ROP case-based training, which is different from the virtual reality that I'm going to talk about. There's strabismus simulator, retinoscopy simulator, and complex strabismus simulator, which we will talk about. An incorporation of CME activities and news articles on one network. We also have a quarterly IPOSC webinar series and many more also attached to this. So this is a very great resource. But today's topic is the simulators. When we started this journey on online education, again, I started with CyberSight with Dr. Helveston, and at that point I was not an ophthalmologist, but through him and his vision, I learned really the power of online education to reach everyone. The Pediatric Ophthalmology Education Center is the first center that actually was able to use the entire armamentarium of the AAO resources, and we made it free for the first time, all the resources that we had under pediatric ophthalmology and strabismus. So that's why it is a very powerful site. And just like where you are in the cyber site, it has been free and available for every one of you. This was meant to be in a very similar fashion, that as well, but just expanding on the knowledge and then adding the AUO platform. There is a lot of synergy that we still continue to this day and beyond, as you're seeing today, the cyber site. So there is that. And when you look at the simulators and case-based training, there are, again, 4 simulated activities on the site that, again, you have a direct access to, and you can access through your smartphones or your laptop, desktop. So it is available for every one of you right now, which actually has been fairly much had a very big traffic. So when we look at the first 5 reasons why people go to the Academy website, individually, the retinoscopy and the strabismus simulators separately are in the first 5 of why people go there, and hopefully you'll see why. And when you go to search retinoscopy simulator in any platform, the first thing that comes up is the retinoscopy simulator. So all you need to do is just click on that, and that's what we're going to do. And you're going to see this website and then a brief explanation on how it works. But you simply click on the Launch Retinoscopy Simulator and it will start as you're going to see. There is a little information on different parts. So there's this Explore version portion, and there's a Test portion. And through that, you can actually put the refractive error. So here in the Explore, there is a particular prescription that you can add. It could be minus or plus. It can have minus or negative plus cylinder of glasses prescription. And it can change the axis of the prescription itself. So this is the prescription, actual prescription of the patient or of the eye that you're seeing in front of you. So all you do is you click the beam as you're seeing and just you move this around. It's just like you're doing the retinoscopy, and it's just this bar. You can toggle or turn that bar into different angles. It doesn't have to be 4 of these. You can do it in any angle, almost in 5 degrees increments. And all you do is along that line, you actually see what the reflex looks like. As you can see, when you shine the light, then you see the reflex that you would see in a patient. And you can see that when I'm moving the light back and forth, the shadow, which is this bar inside, is actually moving in the same direction. And you'll see what I'm talking about. So if I actually turn this to if I was increasing the number that I'm putting, you can see that now it moves in the opposite direction. And wherever I go, it goes the opposite direction. Again, this tells you to add or subtract the sphere power or the cylinder power, whatever is appropriate. When you really have the same amount of power that the glasses or the refractive error that the patient has in front of you, the image is falling on the retina. That's why there is no movement, and it just you can see that the entire red reflex neutralizes in every aspect of in every angle that you're seeing. And this is the principle behind how you do the retinoscopy. So again, all you do is you click and you move along with the axis that you're seeing. There is a working distance. So in the actual patients, for me, for example, it's 150 because of my arm length. And this is also the simulator allows you to work that in as well. And what you do is I'm going to start from 0. So if you have a patient with 150, you can see that I'm moving the light and seeing the reflex. It is with movement, so I need to add plus cylinder. And more I add, you can see the width of the reflex is changing. It's getting thinner and thinner until I really hit that particular power. Then it neutralizes. You can see the difference between this 150 sphere power to the sphere power that I put in the lenses. There's a 150 difference. That is because of the working distance. So when I am putting the lens in front of the patient and doing my retinoscopy with my arm length as you're seeing, I need to put 3 for a patient who has 150 of a sphere to neutralize that amount because of the distance that I'm there. So you can incorporate that depending on what your distance is going to be. And it will give you a refractive error in the minus or the plus cylinder. So let's say the patient has a cylinder. What you need to do is then make sure that you align, and you will see this, and let's make it a little bit more obvious. So in this axis, you can see how wide this beam is. And when I change it to a different beam, you can see this is much more thinner. So there is a difference between these two platforms, the two axes that we have. And that tells me, so what I do is as soon as I get the retinoscopy in front of my eyes and shine a light, I start flipping over to turn the axis in different various degrees to see if there's any difference between basically the 90 and 180. If there is, that tells me there's a cylinder on top of that too. And you want to find the base first, and there are many ways to do this, but this simulator is allowing you to do a stacking method. You can do a different method too, even with this simulator. But what we're going to do is we're going to find the sphere power, the base first. So if I can neutralize that, and when I hit 150, you can see that now this is neutralized, but the 90 axis is not. So that means there is some cylinder on top of this 150. So if I actually start and put exactly the same amount in front of that, all the angles of the skioscopy or retinoscopy that I'm going to do is going to be neutralized. This is now, I found out that the prescription is that, and if it matches that, and this is the minus cylinder, if you're working with a minus cylinder, it seems like the vast majority of the world is. And here we go. You can see both the aspects of the plus and the minus cylinder. So when you're confident and understand these concepts, then you can actually test yourself by hitting the test module. Every time you hit the new patient, a new patient will come up, and you can see that there is a very significant, and again, this is random. I have no idea what this patient has. So what you want to do is when you see these very dull reflexes, you have to go very plus high, very high plus, or very high minus, and let's see which one. You can see that it changed as soon as I went to that. So you start adding, and now you can see that there is this, it's against movement. That means I did too much. Here we go. Now we're kind of in and there is an axis, so you have to align what the axis is with the patient as well. And if you can see this is still minus. And now we neutralized in this aspect. And if we go to 180 and 90, and then you can see that even with the very high power lenses along with the cylinder, now you can figure out what the prescription is. And what you do is when you write it, it will tell you if you're correct. And every time you go in, when you test yourself with this, it will be a new patient. And this is the prescription of the patient. And when you figure that's the case, then it tells you if you've done a good job or not. So this is our first simulator. The second simulator, and we're going to have some time for the questions at the end. So I'm going to quickly pace myself to go to the next one. Is what we call again, the basic type strabismus simulator. There's a basic strabismus simulator, and there's a complex strabismus simulator. Now let's go with the basic type. And this was the first simulator actually that I had worked on with the team. And so it's very similar. You can just launch the simulator. And there's again an explore and a test mode. And there are some instructions here. So let's go through this. You can actually, this simulator does simulate the tropia as well as the phoria. So the manifested deviation as well as the hidden deviation. It could be both, or it could be either or. And as you can see in the x-axis, so it can be having an exotropia or esotropia by clicking on plus or minus values. And as well as if you go with a y-axis, then it can give you a hyper or a hypo situation. You can choose which eye is the dominant. And this is a simulator that unfortunately is very difficult to do alternating simulators, alternating fixation. So we had to choose one eye dominance, and you're going to see how it works. There are certain tools. There's an occluder, so the patient cannot see through that, just like your occluder or your hand. And there's a fixation target that we can move around, and there's a prism in front of the eye. And the prism settings can change. You can turn the prisms, you can increase and decrease the power of the prisms, just like you would have in the clinic. And there's one more tool, which is called the simultaneous prism cover testing. So with this simulator, you can actually do 4 different tests. You can do a cover, uncover test. You can see just cover, uncover either eye. And before that, I'll just show you how you can see that the fixation target moves around. Or you can actually, if you really don't want to see it, you can make it disappear. And here we made the right eye dominant, but we can change the left eye to be the dominant eye. And let's give some, as you can see, if I increase, let's go with the positive, then there's an exotropia or esotropia, and then the right eye being the dominant eye. So if I do the cover uncover in front of the left eye, I can see there's no shift. And when I occlude the eye, the right eye, the fixation switches because the patient wants to see the fixation target or look at us. And you can see the shift as soon as that happens. And if you see this cover uncover and a shift in there, you know that the deviation is manifest. It's there all the time. And here it was on the tropia. So again, it's lied out and it tells you exactly what it is. So the idea is now to try to measure how much of a deviation there is. So what you do is you have to put the prism in front of the eye. And when you put a prism amount, you want to neutralize with the prism the movement of the eye when I occlude. Back to if there was a deviation, when I move the eye, when I occlude the eye, there's this movement because of the angle the patient is shifting. So if I can bend the light appropriately, and maybe you can think about where to put the base. The eye wants to go to the base. Maybe remember it that way, that if you put the base appropriately, the eye appears to be, for the patient as well as for you, optically, that the eyes are more aligned. Then we do the cover on cover again. You can see that there's still a little bit more movement. Seems like I need to increase the amount. And now there is no movement. That tells me that this is the amount of the manifested tropia that the patient has. Now, let's say the patient didn't have tropia, but had phoria, meaning a hidden strabismus. And actually, we know that vast majority of the population, some say up to 70% has some tropia, some phoria, so hidden strabismus. So it is not an abnormal thing, and they may look perfectly straight, but when you do the cover on cover test, you can see that there's no movement at all. But when you occlude and break the fusion between the two eyes, so the one eye is seeing an image and the other eye is seeing an image, if you're fusing the image, if the brain is allowed to put them together, that's how the brain knows how to keep the eyes together. But if you break that and if you dissociate those in this simulator for 2 seconds, then all of a sudden the hidden deviation shows itself. You can see that behind the occlusion, there was this end, but as soon as I remove the occlusion, then there's a reset and the eyes are straight again. And with the cover on cover, you don't see any shift. It could be either eye, whatever, doesn't matter. Or you can do an alternate cover testing without allowing the patient to really fuse by going back and forth with this. And you can see that there is this deviation, but as soon as I allow the patient to fuse, them snapping back to being straight tells me this is purely phoria. And then similar to that, you can measure what the phoria is. And you can see that there is slight movement. And if you really hit the same amount of phoria with the prism, then now you have measured the phoria. Vast majority of the patients doesn't come that easy. It's not either or, but they have this actual problem of a certain amount. And then on top of that, there's a hidden portion of that. And so you tend to get a different measurement when you're starting to do this, and all of a sudden you start doing the alternate, then you see this increase in the deviation like you're seeing in this patient. So we try to put the prism in front of this eye. And by the way, it doesn't matter which eye you put it, as long as you put the base appropriately, it can work similarly. And you can see that there's, with the alternate cover testing, there's still a hidden portion that is kicking in. So the entire thing has to be 60, as we were seeing, to neutralize that. So the tropia and the phoria, the entire amount is 60 prism diopters for this patient. Let's say I wanted to measure just the tropia, and what you need to do at that point is to do what we call a simultaneous prism cover test. What you do is, as soon as you cover the good eye, you have to put a prism in front of the other eye at the same time. This allows you to only measure the tropia. And if you do it just right, and you can see that it's 30 of prism diopters, now we know that's manifest. The total amount was 60. Now you know that the 30 was the tropia and 30 was the phoria. The entire thing is what we measured with the simultaneous prism, sorry, the alternate prism cover testing. Why is that important? I mentioned the phoria, as you know, is a very common thing. So we don't do surgery as long as the patient has a control. We want to do a treatment or a surgery. We want to intervene if we think that the patient is having difficulty or the problem is causing the problem. And particularly if I'm going to do a surgery, I need to know if this is a manifested problem or is it just a phoria that is well controlled and I don't need to do anything. It doesn't really cause any problem unless I'm really tired or ill. The decision is generally done with a manifest. If you see a manifest deviation that is easily either intermittent, by the way, the simulator does not show an intermittency because it's very confusing with the phoria. But if it's a very poorly controlled intermittent manifested or tropic deviation, or all the time present there, then the decision to do something with prisms or surgery kicks in. When we do the surgery, though, you do it for the entire amount. So that's why in the clinic, you see the clinicians do not the simultaneous prism cover testing per se, but they do utilize the alternate cover testing to really see the entire amount, and you do the surgery for the entire amount. So these are the tests that you can do, and you can utilize the similar things with the hypo. And very similarly, you want the eye to come to the base. If I'm going to put it in front of this eye, then that's what you do. And by the way, you can see the corneal reflexes are also showing if the eyes are aligned or not, just to make it a little more easier. But the actual test that you want to do is the cover on cover, and then alternate cover testing, then use the prism to measure. and simultaneous prism cover testing to measure the entire manifested deviation. So when you're ready with understanding these concepts, then you can go to the explore from the explore mode to the test mode. And every time you go in there, similar to the retinoscopy simulator, there'll be 3 different new patients and ready for you to make the diagnosis, and you can test yourself and master. These are the basic types of strabismus. Basic in what sense? These are comitant, meaning the angle of the deviation really doesn't matter. Doesn't change if you're looking straight ahead, right, left, or down. The amount of the deviation that you're seeing is exactly the same. So this is a comitant type of strabismus. The strabismus gets more complicated when we have, let's go to the complex strabismus simulator. Again, this was really growing on to the already made strabismus basic simulators, and the similar concepts. It will give you different aspects of the table now. We're going to see that. Now here we have not only the basic strabismus in a simpler form, there's also an alphabet pattern. So A, V patterns, lambda patterns, Y patterns, they're all, you can play around with that and learn. There's a Brown syndrome, there's a 6-nerve palsy, DVD, and DHD, or you can customize the deviation by playing on these tic-tac or the diagrams itself. And you can, again, add or subtract depending on where you're putting the exophoria and esophorias and entropias and in different directions. You can actually even limit. You can apply a restriction or tropias. This is a very complex algorithm. I think we push the limits of the team on what they are able to do. So this, if you can, sometimes it's very difficult for your students or your patients to understand the problems. This has been a fantastic way for me to really show them exactly what's going on. The other question comes up from the patients, probably you come across this all the time, is, well, seems like my one eye is drifting. Why are you doing surgeries in both eyes or in a dominant eye? You can actually simulate, using these simulators, explain what's going on. And again, just like the basic one, there is a prism, there's a fixation occluder, but this is a much simpler form. We do not have the certain things. We use the occluder and the prism cover testing. Only 3 of the tests are utilized in this one. And each type of deviation has a user input panel. As you can see that you can see if the deviations are different, you can see this in the 9 gaze on how they're changing. And you're going to see restriction and menus. So for example, let's go to a alphabet pattern. And in the tic-tac-toe, you can see that, or this 9 cardinal positions, this is an XT just randomly chosen, 55 in up gaze, 25 prism diopters in the left primary and the right gaze, and actually ortho. And you can now see and examine the patient. You can see the deviation is increasing. Similarly, you can even measure the amount of deviation. It was set to be 25, and you've seen that anyhow, and you can see that the deviation is increasing much more. You can make these measurements. This is a V pattern. Not only you can see that the deviation is higher in up gaze and much lower in down gaze, and the difference between the A and the V pattern is up and down gaze should be more than 10 and more than 15 for esotropia and exotropia of A and V patterns. The simulator does show you what pattern this is. You can change this. You can actually, as you can see, I can change what the deviations are in certain gazes by just playing on these aspects and the tic-tac-toes, and you can change the entire algorithm as you wish. You can simulate what you're seeing, and just by doing this, now we change this in a different pattern. And if you go the other way around, now we change it to an A pattern of an exotropia, and the simulator will simulate whatever you're putting as an algorithm that you're seeing, and just have fun with it. The other, I'll show you quickly, maybe the Brown syndrome as well. The Brown syndrome, the restricted strabismus, we always chose, or the DVD and the DHT, the left eye having the pathology. We all know that, again, the Brown syndrome could be bilateral. Yes, the DVD can be bilateral. It was very difficult to show. The idea is to show through the simulators what it looks like. So that's why we chose to restrict that in that. But again, with the customizable version of that, you can actually put it in any position as you want. We went with the typical 0 to 4 deviation severity. So in the primary gaze, this patient has a 30% diopters of a left hypotropia, which increases, as you can see, in the right gaze because of the limitation due to the Brown syndrome. And you can see it even further is a limitation in adduction and upgaze. And it gets much better. It almost normalizes in that sense in the left gaze. And this is a typical Brown syndrome that we would see. So you can measure all and there's a 6 nerve, there's a DVD. Let me quickly show the DVD. I mentioned that you can decrease and increase the severity. I mentioned it's the left eye, so when I uncover the right eye, nothing happens. When I cover the left eye, it starts showing this dissociated vertical deviation only in the left eye. And you can either break the fusion 2 seconds and see this effect, or you can do an alternate cover testing to see the DVD. Yes, DVD sometimes can manifest itself as well, but this is the alternate cover testing is a fantastic test to see the DVD. As you can see, the typical thing compared to the hypertropia, DVD is a dissociated movement. Only one eye is going up and down while the other eye is stationary. And then this is how you make the diagnosis. And similarly, this is the DHD form of that. Again, when you are confident that you have the entire understanding, you can go to, and there is a test mode as well, and you can test yourself. And so with that, I'm going to go back to my presentation to talk about the last portion I wanted to mention about the virtual reality. So as you can see, these simulators have been very crucial for us to understand and educate our patients as well as our medical students, ophthalmologists, technicians, optometrists, fellows, and for us to learn these concepts and seeing that the simulators were really changing how we are utilizing the education. Again, this is all for free. You can access the Knight Stamp Eye Foundation, again, gave a significant amount of, and that's why we named the Knight Stamp Eye Foundation. This is all thanks to their donations. The initial 1 million was given to the Pediatric Ophthalmology Education Center, which allowed the strabismus and the retinoscopy simulators happen. Now we have a virtual reality platform, thanks to a $5 million donation through, again, the Knight Stamp Eye Foundation. In this simulator, the goal is to put a VR platform, as you're seeing, like this. This is out of box. Again, I have no financial interest on this, and this is all free. All you need to do is have an access to and log in, but through this visor, all you need to do is just buy the Meta Quest, and access to the program will be free for ophthalmologists and residents and fellows. And IPOSC will be the source for distribution for free AO credentialing. And to go into the full version of the platform, you do need an AO login because this has a treatment in it. Scope of practice can be an issue in different countries, like USA it is. ROP treatment and examination, particularly the treatment is the ophthalmologists do that treatment in USA and many other countries. For that reason, we wanted the countries to decide who has a full access to these platforms, and they individually go to their representatives under the International Pediatric Ophthalmology Strabismus Council. Member societies and their members are eligible. I'm going to quickly go through. It took a lot of planning and simulating different versions of the retinopathy of prematurity. We had to 3D module them, and then we tested them in our residency programs. Well, no surprise, my former residency program was the first program that we kickstarted this, and then 2 other residency programs in the US and San Francisco as well as Oregon. And we got their input. And after the input, we went live. This is right now available for every one of you, all the ophthalmologists in particular. And AAO Pediatric virtual reality platform has a desktop version. You can go in and download that as well, and work on your desktop. But the virtual reality is the platform that you really can simulate how to do an indirect ophthalmoscopy in a baby and diagnose retinopathy of prematurity, as well as if the baby in front of you needed a treatment, laser or intravitreal injection, you can actually apply them as well. So let's go through them a little bit. And this is the desktop version. And you go to this, and there's a module list, and there's a full training or a diagnosis panel, similar to what we have done before. You can actually test yourself or play with the program to learn a little bit more. After you've done and be comfortable, if you want to test how you're doing, you go to the test mode. And then that test mode really gives you a full analysis on how you're doing. If your diagnosis is correctly, if you've seen the entire amount of retina, what % of retina you have evaluated, is easily seen with this program. It gives you a full understanding. And I urge everyone to, first of all, to play with the desktop version first, to understand the concept of ROP if you've never done this before. Because learning to do a indirect ophthalmoscopy, if you've never done this before, as we all know, is a difficult thing. It takes some time to really learn the concept of how to use the lens, how to align the eyes and the hands with the fundus. Learning that, as well as learning the virtual reality platform, is not an easy thing to do at the same time. If you've never done the VR, if you've never been in a virtual reality platform, that takes some learning as well. So I urge you, if you go through this, to put on the VR, play with it a little bit. In the program, the AO program, there is a little integration, so learning cues as you follow. It lets you understand the different functions of these haptics, and there are, again, triggers all around. And you can see that there is a little cursor that allows you to move, and there are different buttons that they all have different functions. And this simulator will show you in a very complex fashion on how this all works. I'm going to quickly play. There is what we call a mini tour version. So even if you don't have an AO login, anyone in the world, as long as you have this virtual reality MetaQuest platform. Why MetaQuest? Because that was the most available platform. That's why we chose this. All you do is you upload the MetaQuest program, the AO program, to the VR. You need to have a Meta account. When you open the free Meta account, it's like an app. You download it. You download the AAO app, and there's only one, and that's the Virtual Reality Center. And there's only one module at this point, which is the ROP module. And in the corner, you're seeing this. So there's a play, and there's this. This is the full login version, but there's this mini tour version. When you go into the mini tour, the video will show you how it looks like.
Hi, I'm Dr. Faruk Örge. Retinopathy prematurity.
So when you go into the room where you see you're in the NICU now, a screen pops up in front of you. You're going to see me at this point narrate what this platform is about. And if you've done this before, every time you go in, you don't want to listen to the explanations, you just hit skip. But at this point, I'm going to run this to give you a taste of what it looks like.
Hi, I'm Dr. Faruk Örge. Retinopathy prematurity is the leading cause of preventable blindness in children worldwide. Yet training opportunities for proper examination and treatment are severely limited. That's why the Academy developed this VR simulator for ROP diagnosis and management. This is a short demo tour of the full training experience. Here in the virtual neonatal intensive care unit, you'll wear the indirect ophthalmoscope and use the handheld condensing lens to examine the baby in front of you. All instructions will be on the screen to guide you step by step. You can use your controller to navigate between steps or to interact with your tools. The condensing lens and indirect ophthalmoscope are on the tray next to you. You can place the indirect ophthalmoscope on your head and use the lens to examine the retina. Once you're comfortable with this demo, we encourage you to try the full version for a comprehensive training experience with different patient cases and all the required equipment. You'll be able to diagnose stage, zone, and severity of ROP, and then apply appropriate treatment, be it laser therapy or intravitreal injection, all in a completely safe virtual environment. This immersive training program was built to advance your development and ensure you're better prepared for real-world procedures, ultimately improving outcomes for our pediatric patients. Good luck, and let us know what you think. Using either hand, pick up the condensing lens on the table behind you. Using your spare hand, pick up the indirect ophthalmoscope on the table behind you. Move it close to your head and release the grip to wear it. Hold the lens in the area shown so that you see a magnified view of the retina. Check the retina from several angles, moving your head position and adjusting the lens accordingly. View 10% of the retina to advance to the next objective.
You can see while you're doing the examination that this really, the optics and the different distances that you have from the baby, your head and eye, and the coordination alignment works exactly how you would do an indirect ophthalmoscope, ophthalmoscopy. And this is a 28 diopter lens. The magnification is up to scale. The eye and everything is up to scale. And you can see that you're seeing the temporal retina and the nasal retina. And in the nasal retina, the area that you're seeing on the whole diagram is depicted. During the examination, it tells you what percent of the retina you have visualized. And this report, you can share it with others. And actually, while I'm doing this examination, every one of you could have been in the room seeing exactly what I'm doing, so that, because in my educational platform, I'm asking the residents if they've seen the pathology, and they say yes, yes, and I have no idea what they're seeing. But here, actually, you can see exactly what they're seeing, and so I just want to add that there too.
Take off the indirect ophthalmoscope by holding your hand near your head and pressing the grip button. Move your hand away and release the grip button. Thanks for trying this quick preview of AAO VR education. To use the fully enabled simulator, return to the main screen and log in with your Academy credentials.
Which is right here. When you go to that, it's the login. That's where you log in to. Actually, there you can go into this entire platform. It shows you how to use it. You can actually use this platform to share screen. So if we were all in the virtual reality, we had the headsets, I could have given you this lecture on the virtual reality platform. Then this is the NICU that we built. Here you can actually even adjust the bed height. You're going to see, you just hold this handle and go up and down. And then it shows you how to use the indirect, as you've seen, and the indirect lens, and the scleral depressor. In the actual full version, there is a scleral depressor that you can use with either hand to move the eye around and depress the sclera. There are locking tools, because some of them are very difficult. As we all know, trying to learn all these things is very difficult. You can actually lock certain things in place. Let's say I put the lens in front of the eye and I just want to move around it. You can do that. You have to make the diagnosis. As you're going to see, when you finalize the evaluation, you've seen the entire eye, it will ask you to make the diagnosis. And after making the diagnosis, you can, if you want to do the laser, just like the laser console, you can actually arrange the power, the duration, and the intervals of the laser. It will listen to exactly what you're doing, and the powers are going to be speaking directly as you would see. And then you do the lasering. In the test mode, you can actually do a quadrant. And again, you can draw a Mickey Mouse or whatever you want to do, and it would just, like the laser, if you hit the same spot again and again, it turns brighter and brighter, or if the power is too high, you can see the effects of that. And that we're still working to be a little more coordinated. If you're going to do an injection, then you can use the caliper with either hand and mark the eye. And then this is the injection. And I'm going to quickly show that you've done the injection in front of the eye. Down the road, we are going to work on different things like strabismus surgery. We're going to incorporate all the simulators that you've seen into this virtual reality as well. We're right now working on the gonioscopy angle surgeries, other pediatric retinopathies, and adult retina module will come, and who knows, many more. Maybe this is the one screen that I really urge you to pay attention to. The top one is the link to the Pediatric Ophthalmology Education Center. As you can see, you can Google, you can search any of one of them, it will come up. But this is the main page. The top one is for, again, the Pediatric Ophthalmology Education Center. The bottom one is for the fundamental VR, the ROP, or the Virtual Reality Education Center, where the ROP module is. And maybe I'll stop there and for the last 9 minutes answer some of the questions you might have, and if that's okay while I share the screen. And the first question is, can you share the link for Pediatric Ophthalmology Education Center website? I think we have that link already, so good. So that's that. And this is all recorded. You can go back and find the link. You can search it, so that should be easier. The second one is great learning experience, sir, and great learning experience with fantastic practical demonstrations. I really appreciate your comment. There is I do not. We need a translation for the third question, or the fourth one. I think there is that already. How do these simulators help improve diagnostic accuracy among students and early career practitioners? We have not formally assessed these things. We have informally assessed this, and feel free to do it yourself and let us know and how we can do this. What we are right now doing is, because we can track, particularly ROP virtual reality, everything that you're seeing, how much time if you share that information, you can see how your residents and fellows are really going through the educational, where they're having problems. Like, as I said, many of the national organizations of the ophthalmic and optometric organizations are already incorporating these simulators to their practices, that they actually have them go through these simulators to understand the concepts before they come into the clinic. You can actually do it before and after. That will be your quick test on if they're really working or not. But by the traffic, we're really confident that it has been changing the algorithms of teaching. What are the main benefits of using online ophthalmic simulators in clinical training? Because it's available. And back to why did we start all this? When I was reading the concepts of how to do a retinoscopy, well, it was very difficult to understand unless you've done it. And you need to do practically hundreds of them to really understand and master these concepts. The patients are not patient enough, and you may not have certain pathology available to you all the time. So we wanted a simulator to be in front of you to really understand and do these, so that you can do it, see these pathology and do the examinations as much as you want, wherever you want, whenever you want. It really made people understand these concepts much quicker. I've seen this in 6 continents that I've been around, in various educational teachings that I have personally done, or for our medical students, residents, patients, neurologists, again, optometrists, or orthoptists. There are certain concepts really click in much faster, and that's I think the benefit of that. How are artificial intelligence and virtual reality enhancing ophthalmic simulation platforms? That is yet to come. So down the road, we're going to indeed incorporate the AI, because hopefully we will understand, with the input that we're getting through you or through us, we may really understand where to focus on educational platforms and switch and enhance what we do. So I think that's yet to come. Are there any free or low-cost simulation platforms available for students or institutions in North Africa? Every one of them, as I mentioned, they're all free. They're all available. This is as low cost as you can be. As long as you have a smartphone or a computer of any sort that has a screen, tablet, PC, doesn't matter, you have an access to it. It's free. You don't need to log in for the simulators, as we mentioned, the virtual reality. And the desktop version, you can as mentioned, you can download it onto your desktop. But the virtual reality platform, the Meta, the basic Meta, the first Meta, which is this platform is built for, which is MetaQuest 2, it costs less than $200. That's all. That's the only investment that you need. And you can have thousands of people utilizing these. So all you need is a separate login. We want everyone to have their own login so that you get to see your progression, or you get to see the resident's own progression. So that because it's free, we urge you not to use the same login. That's the only thing that we would say. Is it only in English? So the simulators are really doesn't need any because it's just you simulate the examination. The virtual reality at this point is only in English, but we're working on different versions. How do we access these simulators platform? South Africa, as mentioned, you just log in and you have a full access already. Right now, it's available. What is the role of optometrists in management of strabismus, especially in countries like South Africa? Huge. Not only optometrists, certain countries do not have ophthalmologists or optometrists available in great areas, and I've seen technicians, I've seen nurses, I've seen neonatologists, pediatricians really do what we are doing back in USA. So the idea is to learn these concepts and apply them to your examination skills, and this is available for everyone. That's why we made it available. And it's great to see you, Chiku. What a great resource for educators too. Great session, Dr. Faruk. I will certainly disseminate these resources through the African. Please do. And we are dedicated, as you've seen, that I was personally there. You're doing an amazing job in Africa and beyond. We are fully dedicated to help you in any way that we can, and we will, and all around the world as well. So let us know how we can help. Dr. So, how can one know that his retina is for the left eye or the right eye, especially for the OSC practice? Actually, it simulates the right and the left eye. You're going to see directly, and the eye that you're in is fully simulating the eye that you're examining. Thank you so much for fantastic. So thank you for the comments. You're very kind. What potential impact these tools have an early detection and prevention of eye disease at the community level? Again, the vast majority of what I do in the US is, and we're almost done with the session, so I'm going to probably stop there, but let me make this comment. When I look at what I do in US in daily life in clinic, the vast majority of the patients, 80% plus, not 100%, I use retinoscopy. I diagnose not only refractive errors, which is the leading cause of really blurred vision and amblyopia, but corneal pathology, any visual access problems, cataracts, any even fundus pathology, you can see a difference there. So retinoscopy is a very powerful tool. Then beyond that, giving glasses is an important tool, but beyond that, the strabismus, the misalignment goes along with it. That's the vast majority of the surgeries that I do. Although I personally take care of congenital glaucomas, cataracts, and many other pathologies, IOPs, as you've seen, this is a very common problem. So, and now you've almost touched into the 80% of what we do as a pediatric ophthalmologist. So, and back to the ROP, why ROP as the first module? Because as mentioned, the ROP is the leading cause of preventable blindness in childhood worldwide. Our goal is to make that not the leading cause and don't go down the list. And with this, ROP is a problem we can solve. We just need to know how to and when to examine and eliminate and how to treat these babies. We're hoping these simulators via the desktop, smartphones, or all virtual reality helps us to get there. And thank you for being with me and being with us in the CyberSight webinar. Please forward the questions one more time to the technical team so they can forward it to me, and I'll be more than happy to answer any questions you may have. But thank you for being with us from various countries all around the world, to being with us to further our education. Be well.